All right. Well, good evening and welcome. I'm so glad that you have an opportunity to join us this evening. And the first time we've brought together an alumni town hall. I'm Nicole Wadsworth, Dean of the College of Osteopathic Medicine and School of Health Professions. And I am joined by several individuals that will be talking about AI in medicine and some of their current thoughts on this particular topic. Before we start, I'm going to provide a little bit of an update of NYITCom or NYICOM. Some of you may know it better as when you were here on campus, but things are going incredibly well. We just graduated the class of 2026 on the old Westbury campus, which represents the 45th class graduating from NYITCom. And between the two campus locations, we have a campus in Jonesboro, Arkansas. Some of you may be aware. We graduated our 10th class this year on that particular campus. We are getting close to about 10,000 alumni from NYITCom, which is pretty fantastic. Next year in 2027, we'll be celebrating 50 years of NYITCom. Please stay tuned, more to come as we start to plan those events. And certainly, if you have an opportunity to join us, you are more than welcome. We're also currently working hard and planning and getting ready to welcome the class of 2030, which is kind of hard to believe, the third decade in this particular century. And those students will be joining us in August. Our students are simply phenomenal. You'll meet one of our second year students, Jonathan, who will talk a little bit about AI with us today. But he, along with all of his peers, are doing incredible work. They're publishing, they're doing research, they're doing phenomenally in their curricular academics, as well as matching it to very competitive specialties and representing NYTCOM across the nation. We are currently engaged in incredible research by our faculty as well. We have some special areas that we're focused on, one being imaging. Some of you may have heard of our Biomedical Research Imaging and Innovation Center, where we house both a 3T MRI capable of functional MRI imaging, as well as microscopes that are way more complex and sophisticated than I'll ever understand. But our researchers are doing phenomenal research with these instruments. We also are focusing on cardiovascular research, musculoskeletal research, neurological disease research. Um, and as I start to think about AI, and we've been thinking about it now for a couple of years, seriously in the last 12 months, and many of you are probably seeing this in your specialties and day-to-day life and practice, how AI is disrupting about every single sector we engage with. And medicine and medical education is by far not immune. And I have a couple of folks that again you'll hear from who have engaged, embraced, and are really helping us think about this in a thoughtful way, both to advance ourselves as well as find ways to be more effective and efficient, as well as engaging in other parts of medicine that I'll share in a little bit, I think are even more important as AI uh, joins us, I guess, more frequently in our clinical practice. I was doing a little bit of research just to be curious. I love history, and I was looking at what were some of the breakthrough innovations in medicine 50 years ago, just because we're getting ready to celebrate our 50 years. And interestingly, in 1976, implantable cardiac pacemakers were one of the most stunning innovations in medicine at the time. for most of us, pretty commonplace medical device, but in 1976, it was a brand new technology. CT scanners were just entering the market and becoming a part of what we did day in, day out. Synthetic human insulin was derived and starting to be used. And there was a lot of breakthrough in coronary artery bypass grafting in the surgical field, which interestingly, I imagine many of us are seeing that to be a surgery of the past as more and more technologies enter the space and we treat people with cardiovascular disease. So just interesting to ground some of our thinking as we start to talk about technology. So I'm going to stop here and I'm going to ask the panelists to introduce themselves and give a little bit of background, and then we'll dive into some questions. So I'll start off with Dr. Donahue.
Thank you, Dr. Wadsworth. My name is Joanne Donahue. I am the Director of Clinical Research. I'm also in the Department of Osteopathic Medicine. I have been with NYITCOM for 27 years, probably the longest person on this panel. So I probably know a few people who were on the panel. I started out in our Parkinson's program as a clinician. My background is nutrition, exercise physiology, but that's really taken me in the direction of research. And over the past few years, the reason I am in the osteopathic medicine department is to really foster osteopathic research and clinical research. And I could tell you in the last 2 years that AI has really monopolized my world. It's probably been the biggest game changer for research and clinicians that I've come by. I am a big advocate of it if it's done right, if it's done ethically. And that's really where I go now. I actually speak to other comms about how to integrate it into research the right way and how to decipher information. But my research also still spans over clinical research with our EDS program, our Parkinson's program, and in general, just metabolics. So I will end there on what I do, and I will hand it over to Dr. Toma.
Thank you. My name is stated, and I'm also from the Department of Osteopathic Manipulative Medicine, but my background is less clinical. It's more in a field of computational science, specifically computational biomechanics, where I'm applying how to calculate the mechanisms of how the human body works. So I have a background in applied mathematics, and I'm just applying it to a human body. I've been developing computational predictive simulations my entire life since my high school, and that eventually led me to medical college, where I'm applying the same to training now algorithms for AI, machine learning, classifications and predictions of human body pathologies.
Thank you, Dr. Toma. Jonathan?
Hi, everyone. I'm Jonathan Stark. I'm second year here at NYITCOM on the Old Westbury campus. Thank you, Dean Wadsworth, for having me tonight. And at NYITCOM, one of my main academic interests since I've started has been kind of the intersection between, clinical medicine, machine learning, and also as we develop usage of AI models into our education. I recently co-authored a paper in bioengineering with Dr. Toma, where we looked at machine learning methods in Parkinson's detection. Um, and we really looked at in that study how sometimes machine learning models can appear very accurate, but if you really look at how they're operating, they could really not be translated very well into a clinical setting. And we're now expanding that into another project on early sepsis prediction, where we're focusing on something similar, and that is really clinical realism. And it's whether AI models or machine learning models are using information that will actually be available early enough to change management for physicians that are working in the ICU. Um, and yeah, I'm excited to be here because I think the student perspective is important in this discussion. My class will be one of the first ones to kind of graduate with AI in the sense that we're training in a version of healthcare, and we may be inheriting one that's fundamentally shifted by what artificial intelligence and machine learning is doing. So I'm excited to be here tonight, and thank you guys.
Great. Thank you. Well, I'll share a little bit about how I've been thinking about AI and, in a broader sense in medical education specifically, and a little bit in clinical practice. So, from my perspective, we're not there yet, but I think predictive models and student-centered and singular student-centered focused utilization of these resources can really help us educate students in ways that they thrive in and ultimately can be successful. So from my standpoint, a tool that can help us be better at what we're trying to accomplish, and that is create physicians who are practicing at the very top of their ability. And as we explore these tools and understand what their capabilities are, finding ways to incorporate that into the educational process, I think will only help us. And like I said, I have a belief that it will be very beneficial. Now, certainly it's a tool that can be misused or not used properly, and we're aware of that. And Dr. Donahue mentioned about the ethical use of AI, and we have to bring that alongside of us, very much so. And at the same time that we're engaging with these tools and finding ways to utilize them, the other idea that continues to bubble up for me is re-engaging with foundational knowledge. I think it's critical for our learners to understand those key concepts across medicine in order to be able to use the technology in the most effective way. And so really tuning in to foundational knowledge and skills, I think, is critical in order to be good users of the technology. And communication. I think we as medical educators need to double down, so to speak, on those what some describe as soft skills. I think we need to really focus on them because at the end of the day, our patients are going to expect us to be able to use the technology effectively for their benefit, but we're going to have to communicate with them. And I think we need to really raise those skills up for our students so that they can enter the workforce prepared to manage both sides of this house, the technology side of the house and the human side of the house. Um, so I'm excited for it. I have a perception, and all of you in the field right now could help me refine that perception that these tools can help us be more effective in the clinical environment, maybe unload the day-to-day tasks of a physician so that you can re-engage with that patient care and that patient connection. It's what I read, there are mixed reviews, I guess at this point, but hopefully we will continue to work towards that particular goal. So that said, I invite you, if you have questions, to please enter them into the chat where we are monitoring the chat, and we'll answer questions as we're able to. And I'm going to kick this question off for all of the panelists. How do you think AI will change the day-to-day practice of medicine over the next 10 years? And I'll whichever panelist wants to kick us off.
I guess I'll start off and then I'll hand it off to somebody else. First, I think that now there's a little bit of hysteria with, oh, it's going to replace physicians. It's going to replace so many jobs. I don't think AI is ever going to replace physicians. It can't replace physicians, especially osteopathic physicians who have palpation skills and have to have that interaction. On a positive note, what I see it doing is giving time back to the physician, as you just said, Dr. Wadsworth. It's going to help with the documentation, with prior authorizations. It's going to really help with the workflow of paperwork. I think with probably all the physicians on here right now, most of them would probably complain about the notes, complain about their, pretty much office work that takes up most of their time. I think that's going to give physicians more time with the patient. What I see is more face-to-face time, not when a patient walks in and your doctor is typing on a computer while doing your intake. You're now going to have that face time because it's being automated. It already is being automated. I mean, we do it now in physicians' offices where AI is listening to and taking your notes for you. So I think the biggest change that we'll see is that prior authorizations and scheduling, all that's going to be automated through AI. Now, there are negatives to this, and that's the science side of it. And that's where my expertise really comes into, is more the evidence-based medicine and what physicians use for diagnosis. I know some physicians out there are probably using open evidence or some sort of form of large language model to maybe bounce ideas off of and get a second opinion. And that is where I think medicine is going to change the most. Right now, physicians have access to so much information because of AI. So it's not about physicians retrieving information anymore. It's about, how do you know what is real and what's not real, basically hallucinations. And as working clinicians who are on here, you rely on your organization for guidelines. If you're a cardiologist, you're relying on the American Heart Association for your guidelines. And it's going to be their responsibility now to look through and say what studies are legitimate and what studies are not legitimate. Otherwise, we're basing all our evidence off of fiction. And that, where I think is going to be the biggest problem where medicine is going to go, is deciphering what's real and what's not real among research. But on the positive note, I do think it's going to help with automating workflow for the office.
Yeah, I can add to that about what studies are legitimate and what not. So, especially in diagnostics and using task-specific machine learning AI tools that are supposed to classify or predict some conditions, right? Those can be achieved with high accuracy if the training wasn't conducted properly. If you fed the data to the algorithm and you didn't take care of what the algorithm's supposed to learn or memorize, what it's supposed to do while it's seeking the pattern. If you don't know what to look for, you may end up with something that looks of like ideal on a paper. It returns a 99% accuracy, but then in real life, clinically, it fails catastrophically. So we do have ways of looking at special graphs and curves and their shapes, and those help us predict whether the tool, despite a claim of high accuracy, will actually be clinically applicable or not. So, but the question was how it's going to change day-to-day practice over the next 10 years. Uh, yes, it will, but not diagnostics. I feel like after learning everything about how these algorithms are developed, I don't think AI can diagnose for you. Uh, yes, consider how diagnosis works. A patient with a specific history presents with symptoms. You generate a differential. You consider which pathology is most likely, order confirmatory testing to verify or reject, right? And chatbots are trained on your notes or notes of people before you, on the history of all the diagnoses and notes the prior doctors took, that were taken and fed into the chatbots. Those mirror your thinking, that initial reasoning through probabilistic pattern matching, but the person in front of you is not population data. The person in front of you either have a condition A, condition B, or condition C, and their set of symptoms can be explained by either of the three conditions. Just because 75% of people before this one patient with these symptoms and this history were diagnosed as condition A, it doesn't mean that it applies to this patient in front of you. So the core diagnostic act, integrating AI outputs with clinical context, ordering confirmatory testing, making final judgments, those will always remain yours. AI informs, but never concludes.
Thank
Yeah,
you.
I think that's a great point that Dr. Toma makes. Sorry to just jump in. But yeah, I mean, like Dr. Toma said, AI works best when everything is clear cut, right? So like if it's a clear cut case of appendicitis, you're probably able to, the AI model will clearly tell you, but that's also something that's very easily picked up. But what doctors of, in 10 years from now should know that the chatbot may tell you something, oh, it's probably this with a lot of accuracy. Um, but if it's something that's not as clear cut, that's when AI starts to perform worse, and it will probably pretty confidently tell you, oh, do this and do that. And physicians, you guys live in uncertainty with different lab values, atypical presentations, social factors as part of your jobs. Um, so, that's always part of the clinical decision making, of which, when an AI chatbot tells you something so confidently, when it's not as clear, you'll be the ones probably responsible for, you know, calling out hallucinations and making a decision off of, conflicting material, regarding each patient.
Thank you for that. Jonathan, you sort of underscore my belief that we're going to have to understand those foundational pieces so incredibly well, in order to really understand what we're getting back, and is it accurate, along with the communication skills to make sure we're getting from our patients what we need, what data we need in order to make the right diagnosis, get them to the right care and treatment. So my next question, I alluded to this a little bit in my opening statement. What skills will become more important for physicians as AI becomes more integrated into healthcare?
I think that goes back to what we've kind of were touching upon, but didn't want to dive into completely, and that's probably understanding bias and limitations of AI, which I know Dr. Thomas, and I think Jonathan actually really said it well, because it says it so confidently. When you ask AI, it gives you a decision that's so accurate. And I think a lot of times, a lot of people don't know where the information is coming from on the resource they're using. And I'm just going to throw open evidence. I know a lot of physicians in practice use that kind of to bounce ideas off of. And open evidence does work with New England Journal of Medicine. So it's using validated articles for its information. But going back to what Dr. Thomas said, if you type something in there for a diagnosis and it's pulling all this information from studies, and it might not even be full studies. It could be abstracts it's pulling information from it, because if it has a paywall behind a study, it's not using it, but it'll still pull information from abstracts. And it gives you a response. It could be based on studies that are, 17-year-old Caucasians from Europe, where the patient sitting in front of you is a Spanish 58-year-old woman with diabetes. So that is where you're always going to have a clinical background and foundational knowledge to make your own decision on that. And I know when it comes to bias, that Dr. Thomas is probably the best person to explain that the best. But I do think that that's going to be probably the most important skill set that physicians have to decipher as they move forward.
Yeah, you can't have a physician really be expected to become a computer programmer or an applied mathematician, but they do have to have the skill set now in this landscape in which, they understand enough to ask about these models. How is it validated on what patient population? For example, on the recent study that was published with Dr. Toma, we were able to, without any symptoms of Parkinson's disease, say with almost 70% accuracy that the patient has Parkinson's or not. That sounds pretty amazing, given there are no, symptoms and nothing that would, really clue in a physician to a diagnosis like that. But when we looked behind on how the tool was working and looked at, features of data selection, it was misclassifying almost 90% of people who didn't have Parkinson's disease as having it. And that is a huge problem, obviously, but you wouldn't really be able to tell, because on the surface, I could have just said, oh yeah, it says with 70% accuracy that, it will detect Parkinson's disease, even if you don't have, any symptoms of it. So those types of data selection features, that machine learning models are using is something that, will have to be a part of the physician skill set moving forward. And we start to apply and use these tools.
Yes, we have research going on like this one, where we are developing algorithms to classify diseases or predict outcomes, and we have a class with this on this very topic as well. But the whole point of this exercise is not to teach students how to develop these tools on their own, even though they do that. But the main goal is, through developing these tools, for them to understand how to appraise them, how to scrutinize them, to know what questions to ask. Because if a vendor comes to you, or your CTO, your chief technology officer, if you're in a large hospital, comes to you and they tell you, I want you to buy or use this tool. Now, if you come from NYITCOM, you will be able to say, okay, but because I'm the one giving this diagnosis to my patients, so I want to be very sure that what I'm doing is not going to hurt my patients. So show me this graph, show me that graph. And based on these graph and knowing how to read them, you will be able to predict whether this tool you are about to use that someone is pushing on you or trying to sell to you is trustworthy or not. Because there is a fundamental problem with many of these tools, and that they are, as I said before, they are trained on population-wide data. But you are treating an individual, and you can never predict whether the patient in front of you fits the statistics, right? So, and there is that human connection, explaining uncertainty, navigating goals of care, gathering subtle cues from patient's voice and posture. Those never really enter the training when you're training. By training, I mean training these algorithms. So you do have to rely on your intuition and keep in mind that all of these tools have a large amount of false positives and false negatives. So despite any pressure, you have to always assure, and confirmatory testing is up to you. The AI will not do that for you.
Thank you. I'd like to turn to some of our audience submissions. A couple of comments, which I think are salient, particularly what you said, Jonathan, about opportunities to train AI models. And so they're out there. And so we, as healthcare providers, maybe should avail ourselves to those opportunities to make sure that there's accurate information being provided. And the other comment was about having students involved in training, and we are providing those opportunities to the students and approaching it sort of a multifaceted way currently at NYITCOM to expose the students, and some futuristic thinking on my part. I would love to create an opportunity where students engage with AI in a clinical setting, but in a safe setting where they use the tools and then sit down with a practitioner to understand where the tool was right, where it went wrong, and what we can do to try to mitigate some of those things. So thank you for those comments. Then we have a question, and this is a great question, and it's a tough one, and I think it'll be good to sort of think on a little bit. So, how do we see AI contributing to the strategic transformation of our national disease care system to a real national healthcare system, rather than just being another technology tool for the practice of medicine in the same poor system we have today? And the basis of this, and many of us know this as practitioners, that currently the United States spends the most on healthcare in the world, but both per capita and a share of our economy more than any other country. But our outcomes are not among the top in the world. So I'm curious to hear the panelists' thoughts on how do we see AI contributing to a national healthcare system as opposed to the national disease care system that we're experiencing now?
Yeah, I mean, I think that's a great question because in a worst case scenario regarding AI, it could become simply another layer between the doctor and the patient. Um, versus in the best case scenario, I think this is a situation in which AI may reduce the documentation burden of a physician and allow them to spend more time with the patient, which not only means more information given to the doctor for making appropriate diagnoses, but also just for general rapport and the general, experience of the patient. AI models are great at going through, probably difficult diagnosis and being something you can toss thoughts back and forth with. And being able to make a hard diagnosis, systematic diagnosis of all these tests is a big reason why, we're all here to become physicians. But another reason is just to sit with the patient and to be with them through some of their hardest times. And if AI is something that allows a doctor to do that, I'm very excited for, the future of medicine in which this is not a layer and this is not something that separates the patient and leads to a situation like you're talking about, but leading to a healthcare system in which I'm able to spend more time. I'm empowered to spend more time with my patients, help them through their worst times, help them through their best times. And yeah, hope that answers your question.
Yeah, I mean, I'm not sure. I think Jonathan probably touched on it best. I'm not sure exactly the direct question that was asked through that, but I would say on a deeper level with AI, on a biomedical level, um, that AI can probably it sees things in biomedical sciences that humans just can't. And when it puts, certain drug interactions together or certain advancements in medicine, um, I think that might actually change the way we look at healthcare in general, I think medicine's a lot of pharmaceuticals, obviously. Um, and I don't know, I agree one with Jonathan said that first it's going to help physicians be physicians again, where you could actually sit and talk to a patient, have empathy with a patient, and um, take away some of the red tape that's in there. But I think to improve a healthcare system, I think you got to go down to the deep research. And I know we have clinicians on here and DOs on here, but you have to remember that everything on medicine is based on biomedical research. It's based on research, and I think that's where it's all going to stem from. And I think AI is going to probably improve our system by making that process a little bit easier from the ground up, if that makes sense. How to get new drugs out there that are effective without maybe taking 10 years because we have so much paperwork to get through to get real research out there and things like that. I do think it will speed up the way we can bring treatments, novel treatments out to the general population on that sense. And I don't know if that's answering really the question that was asked, but I'm saying from the ground up, I do think that that's where you're going to see probably remarkable changes in medicine.
This is how I see the question. So, going from disease care to healthcare, I see that it could have some preventative power. Like it could tell you you're heading in a direction of developing something. Right? So this AI machine learning systems, yes, they can classify diseases based on data that you feed to it. It seeks patterns, and if it finds the pattern and you feed that pattern, it will tell you you have a condition A. But it also have a predictive power. It can tell you that based on these features, right, based on your age, your gender, your height, your weight, how many vegetables you eat, how much you exercise, how much water you drink, and all of these lifestyle factors, it can tell you that you are heading towards diabetes. Or like it can predict that if you keep doing these things, if you don't change certain features in your life, you're heading towards developing some kind of a condition, and it can give you this warning, and then you can adjust your lifestyle and things like that. So that would be a power that it could have some preventative effect on population.
Thank you for that. And that was something how I was thinking about it as I read the question. How do we leverage these tools alongside of our patient care to focus on what's healthy or health? And I love the idea of maybe helping them see the future based upon this set of behaviors. This is the potential pathway you're headed for, and that we as clinicians can refocus or help support our patients to focus on health and less disease. And certainly we could have a big conversation about, what care is reimbursed and how it's reimbursed. And that certainly drives a lot of behaviors in our current system. But I think as osteopathic physicians in our training and our approach, these sorts of things make sense to us. How do I help my patient be healthy so that, to your point, Joanne, maybe we can identify the blood pressure medicine that they need that's specific for them, and along with all these other components of health to drive health as opposed to disease. But great question. Thanks for that. A next question, and specifically for the faculty, and I'll kick it off a little bit. But the question is, how are medical schools deciding what AI competencies students should graduate with? And this is a great question. I would say that our accrediting bodies aren't quite there yet from a requirement or a standard that we would have to meet as a medical school. But the employers of our future graduates are demanding some of these skills, and that's where we're going to see the market push on the curriculum in order for our students to be able to graduate and operate within those systems. I think it's really less about the specific AI competency per se, and it goes back to other skill sets that will help the students be successful. And these may sound simple, but I think they're critical. And those include critical thinking and problem solving, to understand what the chatbots are giving back to you, how they work, so you can understand the outputs that you may or may not get, and to have the skills and knowledge to be able to question what's being presented to you as a clinician. So for me, those skills are very important. And then layered on top of that is flexibility, because we've watched the speed at which these tools have been developed and implemented be incredibly rapid. And so I think our students are going to have a degree of flexibility to be able to navigate a landscape that is going to be changing relatively constantly. So those would be the competencies that I would want to really highlight in the face of AI or whatever technology is coming down towards us. So I'll kick it over to the panel.
Well, I'm not sure if everybody's familiar. I know, a lot of organizations like the American Osteopathic Association has this new protocol called Teach, where they want all students to learn some AI technology skills before they graduate. And to be honest with you, there's a lot of people that are saying, oh, yes, we have to teach this, we have to teach this. And I don't think people really know how, because AI is moving faster than we can keep up with. So yes, we all know that they have to graduate with a certain set of skills, but it keeps changing by the week. If we offer a course in 3 months, that course is outdated because AI has changed so rapidly. Where I've gone with my students, what I see is they all use different tools, between a large language model and AI agent. So the skill set, foundational skills will never change. You always have to teach a clinician, whether they're physicians, physical therapists, foundational skills. You have to have that foundational knowledge. Otherwise, you won't even be able to question a large language model. So I kind of go with my students as to what they're using, what's out there, show them the pros of it, have them use it, and let them see their own mistakes. Show them the inaccuracies of how this can go wrong. Again, I use research. I've had students hand me papers that are fully written by AI models. But we don't even have detection yet that's 100% foolproof if they've used AI. So even though I can put it through an AI detector and it'll say it was 90% AI written, that's not fully accurate. And I can't really accuse the students of doing that. But what I can show them is this reference is a hallucination. This reference really wasn't accurate. This diagnosis came from, where did you get this diagnosis? It came from a source that wasn't accurate. So I think a lot of the skills is showing them how to use it, again, ethically, responsibly, and understand how it can make mistakes.
And also by understanding how it forms the answers to your question and where it draws the motivation behind what it says, will make you understand how and why it does sometimes conclude wrong things. And so there are probabilistic models. Those are the chatbots, the language models that they change your prompt into numbers, and then it runs through some algorithm, and then it picks the most likely next word following your prompt. So for example, if you say persistent cough and chest pain, it will return pneumonia because that's the most common answer to those symptoms. But it could also be early onset of lung cancer. So you have to be able to ask the way that it's clear to it that you don't just want one answer, you want all of them ordered in a proper statistical probability and so on, and confirmatory testing suggested to you and so on. But then there is this other AI, and that's the deterministic AI. We have to keep mentioning the difference between those two, because unlike other fields, medicine and healthcare are special in a way that they are irreducibly multimodal, right? If you see a patient, you see their face, you see their facial expressions, you read the tone of their voice, read the secret meaning behind their questions. Sometimes the patients don't tell you the truth, and you have to read all of these little things that are part of your intuition over the years that AI will never be able to understand through just looking at the raw data. So, as a student coming out of college right now, you have to know how to scrutinize the output, and you have to go all the way to the beginning to understand how it forms the output. And that will allow you confidently accept or reject their suggestions.
Thank you. All right, we have another question from our audience. Which possesses the greatest risk to patients? An AI that occasionally makes mistakes, or a physician who ignores an AI system that is statistically more accurate than they are?
There was a study a few years ago. They gave these questions to 25 clinicians and asked them to just use their own knowledge to answer the diagnosis. And then 25 other 25 clinicians who were asked to also consult ChatGPT, and they both were in like a mid 70s percentage accuracy. And even though those who used ChatGPT, they only increased their accuracy by 2%. So there was basically no difference between those who did and did not use the ChatGPT. But if you relied on ChatGPT entirely, you would have mid 90s accuracy, so 20% jump. But that doesn't mean that you should always trust the ChatGPT, of course, or the other chatbots. As I said, they're always come with a mistake. So you necessarily have to listen to your instincts, but don't dismiss the suggestions. Treat it like another colleague when you are going on like when you're consulting a case. Right? If you wouldn't dismiss another colleague's suggestions just because it was different from yours, and that's it.
Thank you. All right, Jonathan, this one's for you. How are students currently using AI AI tools in their studying or clinical rotations?
Yeah, I mean everyone is very different. Everyone learns different for one. I would say most students are using it though, and most students are using it to, create study guides, create practice questions, to create study plans for, board exams and whatnot, and to, reframe, their thinking about a certain question they got wrong or about a certain point on a slideshow. Um, so students are using it, and it's like having a tutor with you at all times that you could always chat and bump ideas off of with. At this level, at the medical school level, I think it's not replacing students. And what I'm trying to say is essentially students still have to learn medicine. And when you're learning for the first time what a loop diuretic does to decrease calcium reabsorption, you still have to struggle with understanding that for the first time. You still have to sit with the material and you still have to struggle with it. But AI is now the resource in which students are using to struggle with that material by saying, why does this happen in with a loop diuretic, for example, or why does this happen during this? So in the same way that, we're using AI now in the same way that I think, doctors in the early 2000s were starting to use Google. And then doctors before that had to look stuff up in a library and find the book. It's just a different way of gathering material and learning and becoming an expert eventually through the years of training. So yeah, that's how people are using it, and it's helping a lot with on clinical rotations. I know a lot of students are using it. They can look up a drug really fast. There's a lot of apps in which student can look up a drug really fast and look up the pharmacokinetics of the drug and the information of the drug, what it reacts with. They can help it write their SOAP notes. They can help it. It can help you give a presentation to your attending physician. So it's being used in all aspects of how a medical student goes through their daily life. Obviously, I'm not going to be in clinical rotations until the summer. But in terms of the preclinical side, it has been, I would say, used very extensively. And there are some students who struggle with using it in terms of, it's hard to learn how to prompt, and there's a learning curve involved with it. So I think, it's important to help to support students in their ability to, learn how to use AI the same way you teach a student in elementary school how to navigate themselves around a library to find the book you want. It's similar premise, and yeah.
Thank you. What is there a recommendation that you might make, specifically Dr. Donahue, Dr. Toma, for currently practicing physicians on how to think about AI, how to use AI? I mean, we've alluded to it a little bit, but more specifically, would there be any recommendations or anything that you would share with our alumni in this space?
Well, before we get into the science specifics of it, to go really practical, real world, and I'm sure there's physicians on here who deal with this every day. You now have patients who have this information at their hand in your office, and they are going to upload their blood work to it. They're going to upload everything you say to it, and they're going to have their own interpretation and say, "Well, AI said this," the same way as when Google came out, except now it's a little bit more details. And I think you're going to deal with patients who are definitely going to question more and say, well, AI told me this, and what's the accuracy of this? I would say, I skipped my first 4 years of medical school. I'm a PhD. So when people ask me medical questions, I think the best way they can learn is first learn the platforms that are the most valid and reliable for clinicians in their fields. Look at it exactly like Dr. Toma says, as is an assistant. It's somebody to bounce something off of. It's not making your clinical judgment. And know your platform so that you can explain to your patient why they should not take AI as their diagnosis and over a physician. I think you're going to spend a lot of time doing that with patients in the future, saying, where did you get this from? Well, ChatGPT told me. Well, did you know that ChatGPT pulls all its information from the internet? Would you go on Reddit and get your information? I think you have to at least familiarize yourself and keep yourself updated on the platforms that are out there that are going to be constantly questioning your clinical judgment. That to me is the most practical, and I'll let Dr. Toma go with more of the science-based questions on that one.
Well, if I was a medical professional and a patient came to me that this is what ChatGPT or Claude or whatever gave me, I would be like, oh, really? Let's check it out. And then do you want me to run this confirmatory testing? In order to confirm this, I have to go and get you CT or something like that. But what to do right now is to educate yourselves on what the different kinds of AI, because as I said earlier, medicine is irreducibly multimodal. I just keep repeating that term. I love it. And you have imaging, you have lab data, You have a bunch of waveforms like EKG, right? You have your own intuition. You see the patient. You see their pupils. You see the trembling in their voice. You see their skin color. You see a lot of things that AI cannot see just because someone uploads their lab data into ChatGPT. Also, you have to understand not just you, but also then you have to communicate to your patients that the chatbots and most of the society now equates the entirety of AI with chatbots, even though it's been in development since 1950s. And the chatbots are only the most recent iteration. They have to understand that you cannot upload all of these data like medical images to chatbots because they are what they are linguistic tools. They are not trained on medical imaging. So you can upload your CT to your ChatGPT and it will confidently tell you that something is on it, but it doesn't mean anything because it was trained on text. It was not trained on medical imaging. For medical imaging interpretations, you need the other type of AI, the task-specific AI, and it has to be tailored to the body part, to the medical condition, to the imaging modality, right? CT, MRI, echo, there are many. So it's not so simple. There would have to be thousands of task-specific AI tools to be able to read all the imaging modalities for all the body parts and for all the medical conditions. So uh, I would, if I were you, I would take one of the NYITCOM is releasing soon the like a micro credentials and in AI in general and also AI in healthcare, and that will teach you the differences between the probabilistic and the deterministic tools and how to scrutinize them. And how then you can go from there and explain it to your patients. Okay, but you cannot upload a CT to ChatGPT. It's not trained on medical images, it's trained on text, right? And then you have to read that CT to the patient because the ChatGPT cannot do it for you. It bothers me that I see a lot of even medical lectures. I go on some webinar or I go to some conference and all they talk about is chatbots. But chatbots cannot do things outside the text on which it was trained, right? So people should be educated on all the different AI types and how they form their answers and how they can be mistaken.
I'm just going to jump in 1 second because I think we kind of went a little bit negative also with the clinical, but there's another side to practice with physicians, and that's insurance and paperwork and the part that probably takes up the most time. And I do feel even if physicians right now are like, I absolutely hate AI, I want nothing to do with AI. I do feel like you will make any practice more efficient by adding AI into the workflow of your note taking and your billing to insurance companies. Everybody knows there's catchphrases, there's a way to submit it to get reimbursement, there's all the phrasing. And this just comes from hands-on experience in our clinic alone, how note taking has been cut in half and how our reimbursement is going up because we now know, you know, AI can help generate how that's being done, appropriately for what these insurance companies are looking for. So if you do have a private practice, it definitely can automate your workflow, and even in a hospital setting, if you're taking notes, it will help you. So you are putting yourself at a disadvantage if you're not using it to that extent.
Yes, definitely. For the administrative tasks, I would definitely use it, but I would be very worried about the diagnostics because it's not there yet, and we'll see where it goes.
Great. Well, in our closing minutes, I would ask the panel for just some of their closing thoughts.
I probably will close with what I started with and just say there's a little bit of hysteria and people think that it's going, AI is going to take over human jobs. I don't think that's ever going to happen in healthcare. I think it might eliminate some aspects of it, but people will always need empathy and human contact and human care. And like I said, if you just look at it as evidence-based medicine is your clinical expertise, your patient values, and the evidence. And right now, the biggest thing that's being impacted is the evidence. And that's what you're going to have to decipher. That's where there's more work put out for you, is to make sure that the evidence is accurate. But don't be scared of it. And use it to your advantage. Like I said, exactly what Dr. Thomas said, just be careful with diagnosis, but you can use it to automate other things that have really been a disadvantage to the healthcare field for years.
So now that it will help you to reduce the workload when it comes to like note taking, synthesizing the notes and so on, and the other administrative tasks, and maybe like a pre-label some images for you so you can just go straight to look at the pre-labeled one and so on. So it will help you streamline certain things in practice, and I would be worried that now the administration will see it as an opportunity to push you into seeing more patients. Right now you have more time, so you can see more patients. So instead, try to spend more time with the patients, and AI cannot replace the way you present some news to the patients and their families. So
Yeah, I think it was a great discussion tonight. And in terms of coming into medical school, AI was just coming out, and then now I'm a second year, and how much it's changed and how much my study methods have changed because of it. I'm probably someone who uses it more than the average student, I would say, for my studies. And how much my studies have changed, and I would never have really envisioned me being able to have like the power at my fingertips of what I'm able to do with certain study materials and whatnot. And like we've touched on, I think this could be used as a tool to really empower patients with more information to bring to a clinician, but also being able to spend more time with the patient, spend more time face to face, see more patients, see patients that otherwise would not have been able to be seen, and getting them access to specialty care in places that would not have, had that opportunity. And with that being said, there are risks and there are things to look out for. An AI model that is trained on bias will perpetuate those biases, and a clinician who's not trained to see these patterns will bring that bias onto their own patients. So there's always things to look out for, and it's always changing so fast. So um, being able to use it as a clinician and as a doctor, and doing the best for your patients is going to be challenging, and it's going to be changing, but it's going to be I think a bright future ahead. So
Great. Well, I want to thank Dr. Donahue, Dr. Toma, and Jonathan for joining us tonight for this great discussion. I'm grateful for all of you who joined us. There were several questions still in the chat. We will address those and get back to you. This was really great fun, and I was glad that we were able to have our first alumni town hall, and I look forward to future events. If you have ideas or other thoughts or ways to engage, please let us know. We are happy to consider those things, and we want to find more ways to engage with our alumni. Please join us in any number of our events coming up for the rest of the year. One of the questions was around our wellness conference. So we host a wellness conference. This year it will be in October at Mohonk Mountain. So I encourage you to join us, and there will be CME available at that conference. We have other events such as the golf outing, which happens early in August, the first Monday in August. So if you play golf or you just like to hang out at a country club, please come and join us. It's lots of fun. And then we have a number of other events throughout the year. So please look for those emails and communications from the alumni office, and join as you're able to. So again, thank you. Thank you to the panelists, and I hope everyone has a great night.